So I'm going to talk to you all a little bit today about how skull-base surgery has evolved over the last 20 years from being a very invasive type of surgery to get to a very difficult place to something that's become much more minimally invasive and much better tolerated, and show some of the data I produced to try to support that whole effort. So I'm going to start talking a little bit about the history of skull-base surgery. And as is all known, this famous saying by George Santayana, those who do not remember the past are condemned to repeat it. So it is important to take a quick look back before we look at where we are now and try to figure out where we're going. Another great quote, telling the future by looking at the past assumes that conditions remain constant. This is like driving a car by looking in the rear view mirror. So things are always changing, and our field of neurosurgery is constantly changing. And I think this talk will give a bit of an overview showing how it's changed. We like to think that we're fairly far along in our evolution, although we're probably back here. At least I hope we're back here, and I think we have a long way to go. But the good news is we're probably not at the beginning of our evolution. So I'm going to talk today about skull-base surgery. So what is skull-base surgery? It's traditionally been one of the most difficult areas to access surgically. The skull base is surrounded by several critically important nerves and artery. And in order to get there through a craniotomy requires significant retraction of the brain or incisions in the face. And it has in the past been very highly morbid. So this is obviously the cortex, the skull top, as we would say, or this is the top of the cranium. When you remove the brain, you get to the skull base. And as you can imagine, it's a hard place to get to because it's protected by the brain and by all the facial structures. So that's the skull base. When we look at it in the sagittal plane, it's this area here that is the skull base. Now, traditionally, and this is how I was taught, we would get there by doing a craniotomy. And a craniotomy involves moving the brain out of the way. And you can get retraction injury to the brain when you do that. So about 30, 40 years ago, people collaborated with ENT surgeons and head and neck surgeons to develop these complex approaches to try to remove a lot of bone to get to the skull base rather than retracting the brain. And these are just some examples of some of the approaches that try to get us to the skull base. But what you see is that they're better at exposing the nerves and the arteries than the actual skull base. And often the pathology lies behind those structures. So these approaches, while great, often cause a lot of morbidity. Big incisions are required, often in the face. There's a lot of removal of bone to try to avoid brain retraction, but nevertheless, you still have to retract the brain significantly. This shows frontal lobe retraction. These openings often require complex cosmetic closures to prevent CSF leak and are pretty disfiguring and morbid. This is a maxillary Lefort osteotomy that's done to go in through the mouth in order to get to a place where we can get to very easily with what I'll show you, which is an endoscopic skull base approach. And because a microscope was used for illumination in these surgeries, a lot of retractors were also used to create an opening. This is an opening in the mouth to try to get where we need to get. So there was an approach that's similar to what we do now, but it had limited exposure. And that was what we call the transsphenoidal approach, and involved a sublabial incision below the lip. And then you'd put a retractor in on either side of the nasal septum. But because you were using a microscope, you really couldn't see that much. And you had a long septum called a Hardy retractor that limited your field of view. Now, the idea was to replace this craniotomy that requires brain retraction to get to the skull base from above and try to basically flip everything over because the nerves and the arteries get in your way. And by using this transsphenoidal approach, but modifying it so that we only use your nostrils to get in, we could open up the sinuses, which are mostly air-filled, and expose the entire base of the skull. And then by drilling out some bone, we could basically approach these tumors from the underside, in which case you get to the tumor first and you get to the arteries and the nerves afterwards. So that just shows you the tumor being removed. So The history of the transsphenoidal approach dates back to the 1800s, 1900s, where surgeons would first go in through the glabella, which is the bottom of the forehead, make an incision there to try to get in through the nose. This guy named Herbert Schlaffer in early 1900s developed another approach where he would literally flip the entire nose off to the side in order to get where he wanted to get. But the transsphenoidal approach that I showed you with the speculum was developed first by Coker, Hirsch, and then Cushing, Hardy, and Guillot. Cushing actually used it and then abandoned it in order to try to minimize the damage to the brain and the face. But the key was the introduction of this, which is an endoscope. The advantage of the endoscope is it has its illumination and also its lenses at the very end of the tip. And by advancing the tip in, you could see much better. So the microscope on the left has its lens and light source at the back of the narrow tube, which would be the Hardy retractor. So you only see a little bit of Mr. Tumor's head. But if you put an endoscope through the nose, you then get your lens and your light source at the tip, and you can look around and you can see much better. So this is the concept, using an endoscope to go through the sinuses to get to the skull base. And this is what it looks like when we do our surgeries, and you can see how minimally disruptive this is compared to the approaches that have been used in the past. And this is the view of the entire skull base with an endoscope. You can really see everything, and you can see it from a completely different angle. So the endoscope also has a bit of a history that I can talk about, and it starts out with just the speculum, which we know well and is still used to get into some orifices and cavities today. This is just an ancient Roman speculum, but this guy named Bozzini invented something called a Lichtleiter, or a light conductor, in 1804, where he would advance a light into a cavity. It was basically a candle with a mirror and a funnel-shaped tube. It was never really used clinically. This is just an example of what that looked like. And then this device was developed again over time. I don't have the name, you can't see here, sorry. But endoscopes developed over the years. This guy, Maximilian Nietzsche, placed a platinum lit tip inside a cavity, and he wrote the quote, "In order to light up the room, one must carry the lamp inside." So the idea of bringing a light into a cavity was developed by him. Victor de Lespinasse is a urologist. We did the first neuroendoscopic procedure going into the choroid plexus using probably a urology scope. The lenses and the scopes we use today were invented by this guy, Harold Hopkins, in 1966, which is that rod lens system. And by having a rod and going along the way in a straight system with lenses, the resolution is very, very high. And as you can see also at the tip, the light goes out to the sides, giving you a much larger radius of view. And then camera resolution also developed. And obviously using CCD cameras, we now can put those cameras at the other end and project those onto, initially we had standard definition, then we had high definition, and now we have 4K cameras and 4K screens that increase our resolution. Fiber optics are also used a bit, and we do have flexible scopes that we use, and these can have a chip on the tip. You can put your CCD chip on the tip and LED light, but we tend not to use the flexible scopes. The resolution is not quite as good. And we also have multi-angled scopes, so we can look around in different directions, although I tend not to use these that often. This just shows you an example of doing a surgery with a standard lens, where we're kind of going in and we can see a certain amount. It's probably a 30-degree lens, so we do get some angled view. And then this video, see if I can start it, will show you the view you can get with this 90-degree lens, where we can go into this cavity and then actually turn a dial and look straight up. I'll show you that in a second. There we go. So we're turning this dial and looking 90 degrees. And then so, you can always have different degrees of view that allow you to see things that you otherwise couldn't see deep into cavities. So the question then becomes, well, we have these traditional craniotomy approaches that we've been using for years to remove tumors, and now we've got these new endoscopic, minimally invasive approaches. How do we tell which is the best approach? How do we know which one we're supposed to do? The new ones, they seem better, and they're certainly easier on the patients in some ways, but do they accomplish what we want to accomplish? Do patients get out of the hospital sooner? Are the surgeries longer or shorter? Do we get out the whole tumor or not? So those are some of the questions I'm going to go through. So I'm going to talk first about craniopharyngiomas. So craniopharyngiomas are tumors that come off the back of the pituitary stalk. So they tend to be right at the base of the brain. When you do a craniotomy, as you see on the left, and you come down on the craniopharyngioma, what you see are the optic nerves and the carotid artery and the perforators. You don't really see the tumor very well. And when we come in from below using an endoscopic approach, you can see here the tumor has actually been removed, but you can see the optic chiasm, pituitary stalk, and the A1, ACOM, A2 arteries from below. It's a completely different view. So I'm going to show you here is a video of taking out this tumor. So this tumor is sitting above the pituitary gland. You can see the sphenoid sinus here, and really at the base of the brain. So it's a hard place to get to, and it extends up into the brain a bit. But with this surgery, using endoscopes, we can drill out the sphenoid sinuses, open up the dura, and then get right into the tumor from below. Our opening is very small. This is probably a 1.5 centimeter opening. And we debulk the center of the tumor and then start to work our way around the outside of the tumor. Use microscissors to cut and dissect the tumor here off the back of the optic chiasm. Here we're dissecting the tumor off the pituitary stalk, trying to save the stalk as best we can, and then dissecting it off the third ventricle and hypothalamus and removing the whole tumor. So here's our post-op MRI scan. You can see the normal pituitary gland, the stalk. This is a nasal septal flap that we use for closure, and the tumor is completely removed. Now, because we don't retract the brain, there's no damage to the brain. And this is an example of a tumor pre-op and then post-op showing flare, which is very sensitive to edema in the brain, and there's no flare signal in the brain whatsoever. So I published an article a few years ago now where I looked at extent of resection, complications, and results of visual improvement, comparing transcranial surgery with endoscopic skull-base surgery. And because endoscopic skull-base surgery really didn't get going until the late 2008, 2009, I divided it into cases reported before 2012 and after 2012. So you can see this is already a couple of years old. But if you look at gross total resection rates with transcranial surgery, there was a range for sure, 40 to 90%. And before 2012, on the upper end, we didn't really hit the upper end of the craniotomy range. But after 2012, 2017, basically the extent of resection rates were the same, maybe slightly better. When you look at the rate of CSF leak, which is one of the risks, possible complications of endonasal surgery, because you're coming in from below, you're going into the brain, there's cerebrospinal fluid, it's going to leak into the nose unless you close. The risk of leak with a craniotomy is about 4%. And early on, that risk of leak was actually pretty high. It was 18% with endoscopic skull-base surgery. But with new techniques, it's come down. And in many centers, in more recent years, they report rates as low as 3%. The most dramatic improvement was in visual outcome, because when you come in from below, you don't have to retract the optic nerves at all. And visual improvement was only 0 to 47% for craniotomy. Now, before 2012, it was about 56%, which is already higher. And then after that, it went up to about 90%. So as our techniques improved, our visual outcome results were much better. So the gross total resection rates are about the same. The CSF leak rates, if you have experience, should be about the same. But the visual improvement rates far surpass transcranial surgery. We did another study at Cornell, because one of the criticisms of the prior study I told you was that when you do a review of the literature and you compare two different approaches, you can't assume that you're removing similar sized tumors. Transcranial surgery can take out a tumor of any size, whereas endonasal surgery, you're only going to use to take out the smaller tumors that are maybe less than 4 centimeters. So you really need to compare apples to apples, not apples to oranges. And you only need to compare cases that could be removed equally well with either approach. So I did that actually. We did a study where we looked at all the craniopharyngiomas removed at Cornell. We took all the cases and we sent them to 4 experts. And the experts not at Cornell said, yeah, you could take this out either through a craniotomy or endonasally and get a gross total resection. Doesn't matter which approach you use. We ended up with 21 endonasal and 5 transcranial. And then we compared their outcome. So we're looking at similar sized tumors. What we found was gross total resection rates were higher with the endoscopic approaches. The changes in flare in the brain, the edema in the brain was much lower than transcranial, as I mentioned. And then the need for radiation and the recurrence rates were much lower for the endonasal approaches. With respect to vision, improvement was much higher in endonasal compared with transcranial. And complications, there were no cognitive defects, but there are actually quite a few from brain retraction in the transcranial cases. There was one CSF leak with endonasal, which we didn't have with transcranial. So that kind of showed us that the transcranial approaches probably were better for most craniopharyngiomas, particularly ones that could be removed that way or selected for that. Here's another disease that we changed the treatment of, and that's this thing called basilar invagination, where the tip of the odontoid pushes into the cervicomedullary junction, also called basilar settling. It's part of platybasia. And this was traditionally done transorally. So you'd open the mouth, put retractors in and drill out the odontoid. And then it was noticed that you could probably get there through the nose and just drill out the odontoids through a transnasal approach. I'm not going to show you a video of that, but I will show you some results. We did a literature review, basically showing the higher rate of improved clinical outcome in the endonasal endoscopic group. And the other thing was, because we were going through the nose, not the mouth, we could extubate the patients much faster and we could start feeding them much faster. So if you do transoral surgery, it takes about 4 days to extubate the patient, whereas you can extubate them right away endonasally. And for feeding, for the transoral approach, you can't feed them for over 5 days, whereas in this review, they were feeding patients at around 3 or 4 days. And also I'll show you when we looked at our cases, and this was 9 patients. We've now done about 40, but this was published many years ago. We were able to feed them post-op day 1, so they did quite well. Chordomas is another skull-based tumor, one of the most complicated skull-based tumors with the highest morbidity arising from the clivus. And this kind of approach on the upper right, extended skull-based approach, would be used to get there, and it's very hard to get to the clivus through a craniotomy, whereas it's very easy to get there through the endonasal endoscopic approach and get a great view. So when we look back at the literature, did a literature review of extended resection, CSF leak, neurologic deficit, the results were pretty dramatic for chordomas. Gross total resection rates from craniotomy were about 50%, whereas for an endonasal approach, it was higher, usually at 60 and even 60 to 70%. It's very hard to get a complete gross total resection for a lot of these tumors because they wrap themselves around the nerves and the arteries. CSF leak rate was actually higher for the cranial approaches than the endonasal approaches. But the most dramatic part was in this neurologic deficit. Because you were going through the cranial nerves, there was a lot of morbidity for the transcranial approaches, but the endonasal approaches had very low morbidity. So again, we showed that we could do a better job using these endonasal endoscopic approaches. Meningiomas are one of the most common tumors that we remove. People traditionally have used this Simpson grade, and I've written a couple articles saying why I do not think we should be using this grading system anymore. But basically, it says the more you take out of the tumor, the less likely the tumor is going to recur. These are benign, slow-growing tumors. And a lot of papers have come out also saying that we should abandon the Simpson grade. It doesn't really make any sense in this day and age. But not all meningiomas are amenable to endonasal endoscopic surgery, these minimally invasive approaches, because meningiomas present all over the place. And you only want to take out the ones that you can get the whole tumor out, because we know that the more you take out, the less likely it's going to recur. So that includes tumors of the planum sphenoidale, tuberculum sella, and then I'll also talk about olfactory group meningiomas, which are up here further anteriorly, which I don't like to take out endonasally, and I'll go over that. So you can do a craniotomy and come in from above, or you can go in from below. And we wrote a couple papers on this showing how important it is to open up the optic canal. A lot of these tumors creep into the optic canal medially down here. Here's the optic nerve. So in order to get this tumor out, you got to open that up. But as you can imagine, if the tumor were coming in through the nose from below, here's the optic nerve, we can get this part out. But if the tumor goes out here, we have a hard time taking out that whole tumor. So here's an example of a tumor. It looks like it's wrapped around an A2 branch there. It invades the medial optic canals. I'll show you how we do the surgery. First, we harvest a vascularized nasal septal flap coming from the septum, take down that whole flap. We use it for reconstruction. Open up the sphenoid sinus, remove all the bone at the base of the skull underneath the tumor, and then start internally decompressing this meningioma. And we can start to decompress it and take pressure off the nerves, without even seeing those nerves, which is really nice. But these tumors tend to be very stuck to the arteries and the nerves. So you can't just pull on the tumor. You have to carefully find the capsule and then dissect around the capsule. And here you can see we're internally debulking the tumor with this device that causes cautery. And then we're sharply dissecting the A2 branches off the nerve. Here we're, off the artery. And then we're opening up the medial optic canal here and dissecting the tumor off the nerve, the optic nerve, rolling the tumor out very carefully, slowly, meticulously, opening up the contralateral optic, exposing the optic nerve, and then sharply dissecting the tumor off the optic nerve. Here we're opening up the top of the sella, cauterizing what's called the superior intercavernous sinus that leads you to the top of the pituitary gland, exposing the stalk, and then taking out the tumor. So you can imagine that the risk of meningitis, if you can't make a good closure here, is going to be pretty high. You don't want the bacteria in the nose to get into the brain. So we do a closure called a gasket seal. There's a bunch of different closure techniques, but most of them involve putting in different layers of tissue and then a vascularized flap to prevent leak. So here's the post-op film showing you a complete resection of that tumor. Here's a tumor we did not take out endonasally, and the reason is that this tumor goes lateral, farther lateral, and is also wrapped around the optic nerves. Here's an optic nerve here, here's an optic nerve here. You can see the tumor is circumferentially wrapped around the optic nerves. It'd be very hard to get that out endonasally, much easier to do it through a craniotomy. So if you look just at planum and tubercular meningiomas and you compare results, through a craniotomy, gross total resection rates are 86%. And before 2012, the endonasal endoscopic approaches were not as good. But in the last couple of years, we've gotten better at doing these and also better at selecting the right cases. So the numbers and the extent of resection has gone up. CSF leak rate was much higher for the endonasal approaches, but that's gone down. And now in some centers, there's less than 5% or even 0%, which is fine. But again, it's the visual improvement, the neurologic outcome that's much better with the endonasal approaches. And that visual improvement rate goes up to 80 or 90%, whereas for craniotomy, it's as low as really 60%. So that shows you the advantage. And so for well-selected cases, not for all meningiomas, but for certain meningiomas, it makes a lot of sense. So we did the same study we did with craniopharyngiomas with meningiomas, compared tumors that were the same size, sent them to 3 experts, had them make sure they were all the same size and could be taken out with either approach. And then we could compare the results. So we had 18 taken out endonasally, 15 transcranially. They were the same size. There was no statistically significant difference. Preoperative edema in the brain was also not different. Gross total resection rate was higher with endonasal than transcranial. We didn't have enough for statistical significance. Extent of resection was also slightly higher, but wasn't powered well enough for statistical significance. But the flare signal edema in the brain was significantly less. DWI, which has to do with infarct volume in the brain from surgery, damage to the brain, was much less with the endonasal approach. And as I mentioned before, visual improvement was better in endonasal, and also visual deterioration occurred in 40% of transcranial and none of the endonasal. Complications were slightly higher in transcranial than endonasal. Wasn't significant, but there was some evidence of that. So we really think that the key to these is case selection and surgical experience. Make sure you know what you're doing. Make sure you select the right cases for meningiomas, and they should do well. We then wrote a paper kind of looking at what correlates, how do we select the cases that we're going to get out? And we looked back at all of our cases and tried to figure out what predicted it. We created this score called an optic canal laterality score, depending on how far over the optic nerve the tumor went. And we looked at a series of patients and what correlated with not getting a gross total resection. And so older patients, we weren't as good, but prior surgery, if it was a reoperation, we weren't as good at getting a gross total resection. Edema did not make a difference. Tumor diameter did not make a difference. There's a tumor diameter score, didn't make a difference. The canal invasion made a bit of a difference, but we go on and show that that really has to do more with the laterality score. ICA encasement makes a difference, but only if it's 360 degrees encased. Anterior cerebral artery encasement did not make a difference. Optic nerve laterality, if the tumor goes past the mid to lateral part of the nerve, then you're going to have less of a chance of getting it out. Tumor diameter didn't mean anything. So the variables were important were prior surgery, optic canal invasion, complete ICA encasement, and a greater than 100% extension over the optic nerve. And you could create a score. So if your chance of getting a gross total resection based on score, you could predict. And if your score was a 0, 1, 2, or 3, you got a gross total resection most of the time. But if it was a 4, 5, 6, or 7, you really did not get a gross total resection. What about olfactory group meningiomas? So these are meningiomas that are a little more anterior. They're in the area of the olfactory nerve, and traditionally they're removed with a craniotomy. That's just showing you an example of taking these out through a craniotomy. And if you look at this report, this is 100 olfactory group meningiomas removed through a craniotomy, and they look at their complication rates. They actually have pretty high, 14% rate of brain swelling, 10% rate of bleeding in the brain, almost 4% rate of death. And they don't even look at anosmia as a potential risk, right? And you're talking about a tumor that's around the olfactory nerves, and they don't even consider anosmia a risk because they just assume everyone's going to get anosmia. So just keep that in the back of your mind. There was then a report of people trying to take out these meningiomas through the nose. And we tried it as well, but this was one of the largest series, 50 patients. And their results, this is a very good center, their results were not so great. Length of surgery, 9 hours, length of stay in the hospital, 11 days. A third of patients needed reoperations, a third to repair CSF leak, a third to take out more tumor. Gross total resection rates, if the tumors were greater than 4 centimeters, was low, about only 45%. And post-op anosmia was 100%, which really is not so great. So here are those complications: CSF leak 30%, respiratory failure 8%, hydrocephalus 6%, brain abscess 6%, and even CSF leak. When you look at before and after they started using nasal flaps, it really didn't make much of a difference. So the question then becomes, which of these two cases is better for endonasal? And the answer is neither. Sorry about the phone, because the one on the left is going to have their sense of smell intact. Olfaction is going to be completely intact. And if you take it out through the nose, they're going to lose their sense of smell, even though you could do it. The one on the right is too big. You're not going to get the whole tumor out. And even though they may not have their sense of smell, since such a big tumor, you're going to have a subtotal resection. And sense of smell is really important because your sense of taste is also integrally related to your sense of smell. So if you look at the rates of olfactory preservation, olfaction preservation with endonasal surgery, it's essentially 0%. But if you do a craniotomy, you can save olfaction about half the time. And particularly if they have pre-op olfaction intact, it's 85% preservation. And if their tumor is less than 4 centimeters, 80%. So if you compare craniotomy to endonasal, for olfactory group meningiomas, transcranial gross total resection rates are 90%, endonasal 70%, no matter what time era you look at. CSF leak rates 11% for transcranial, 30% for endonasal. It really didn't get that much better. Visual improvement might be a little bit better, but anosmia is much worse. So we do a poorer job of preserving nerve function as opposed to the other cases where we did a better job of it, and the complications are higher. So I don't like to do endonasal surgery for olfactory group meningiomas, but I do like to use a minimally invasive approach, and that's a little eyebrow incision. And you can make an incision in the eyebrow, do a little craniotomy, come in from the side. And what I did was I actually first started doing endonasal surgery, and I did 6 cases, and I really was not happy with the results. So I started using an eyebrow, and I compared the results of those 12 cases, 6 and 6. And my gross total resection rate with the eyebrow incision was 100%, and with endonasal was 50%. Anosmia was only 50%, 57% with eyebrow incision and 100% with endonasal. My complications were 0 with an eyebrow incision and 16.7% with endonasal. So I abandoned the endonasal approach. If you're worried about the cosmetics, this woman gave us permission to use her picture. She had an eyebrow incision. You can't even tell which side she had it on, but it was here. You can see maybe a very, very thin scar. Here's another woman, very, very thin scar. So how do we take out a big tumor like this just going through someone's eyebrow? Well, after you make the incision, you have to drill off the roof of the orbit, and you take off the rim of the orbit, and you open up the dura, and you do retract the brain, but you can only retract it very little because there's such a small opening. You get right to the tumor, you internally debulk the tumor. You can take out the majority of the tumor with your microscope, but then you get to a point where you can only see so much. And then you have to put the endoscope in. And if you put the endoscope in through the eyebrow incision, you can see the residual tumor that's down in the cribriform plate. And you can get the rest of the tumor out with angled instruments and an endoscope. So here's the post-op MRI scan. So these are some of our results, 17 patients, tumor volume pretty big. Let me just move this thing, it's blocking here. Flare volume didn't really change, so the brain retraction wasn't that high. There was a little bit of DWI, so we do, cause a bit of injury, but much less than if we did a craniotomy. Length of stay was 3 days instead of the large length of stay you get with an endonasal approach. We had 11 patients with greater than 2 years follow-up. There were 2 recurrences, but it's very easy to manage those recurrences. One just with stereotactic radiosurgery, so the patient didn't even require another surgery. And one had tumor going down into the nose that really needed another surgery to get that out. New post-op anosmia, only 20%. So we did very well with preserving the sense of smell. So the limitation with doing the eyebrow incision is you can't drill out the cribriform plate, but you don't really need to. You can treat it with stereotactic radiosurgery. And if you look at the results of stereotactic radiosurgery, this is tumor progression, only 5% if you do radiation. And causing anosmia with radiation is also very low, zero cases in this case series. So we published another article looking at our algorithm for which minimally invasive approach to use for anterior skull-based meningiomas. Last, I want to talk to you about an eyelid approach that I started doing a couple years ago, working with the oculoplastic surgeon. You can actually use the orbit as a corridor to the skull base. I was a little hesitant, as you can imagine, because the eye is very delicate, sensitive, important, and it's filling that orifice. It's not an empty orifice like the nose is, but you can retract the orbit out of the way a little bit. It's very soft, and find a little corridor, drill out some bone, and get a totally different approach that you otherwise couldn't get. So this is a Meckels cave schwannoma that we traditionally remove through a craniotomy and a subtemporal approach. And I did one. You can also do it endonasally. As you imagine, you can come in through the sinuses, come in here, but the carotid artery is in your way. So you have to come in this way. But if you're coming in this way, it's very hard to get this tumor out because you have got a weird angle here. So sure enough, when I tried to do this tumor endonasally, I left some tumor in the posterior fossa there, which we later treated with stereotactic radiosurgery. So that's the endonasal approach to this tumor. That's the subtemporal approach. But the transorbital approach goes like this. It goes down the long axis of the tumor. And there's very little retraction of the temporal lobe. And I'll show you how we did this surgery. I learned this from a guy named Doo-Sik Kang in South Korea. He's the one who does this probably more than anyone in the world. So here's a case we tried to do. You might be able to hear my my voiceover, but we basically, once you retract the orbit out of the way, you can drill out the bone of the sphenoid bone, and that exposes the dura of the temporal lobe. And you have to cut this band called the meningioorbital band that goes between the temporal lobe and the orbit. And then you can retract the dura of the medial temporal lobe out of the way and open up into the front of this tumor. We're working with an endoscope. The orbit is to the left, temporal lobe is to the right. We're into the tumor. We use the same instruments that we use for endonasal surgery, and can internally debulk the tumor. and then go all the way back to the brainstem. Now, these tend to be not very vascular, which is helpful. Here, we're removing the tumor from the posterior fossa, and you'll see the trigeminal nerve splayed out medially, which obviously we try to preserve taking these tumors out. There you can see the fibers of the trigeminal nerve. And there is CSF, so we close it with 2 layers of alloderm, some fibrin glue. We did remove some bone of the lateral orbit. We close that, and then we do a plastic surgery closure. So there's the post-op scan showing you a gross total resection of the tumor. And you can see the bone removed in the 3D CT reconstruction on the right. And you can also see our little closure that we did here with those graft materials. So that's the end of the talk I wanted to give. I just want to conclude, neurosurgery is becoming less invasive, but not at the cost of less aggressive. Technological innovation will drive our field, no doubt. Less invasive surgery will mean fewer complications, faster recovery, shorter stays in the rehab service. Our minimally invasive approaches are completely replacing open approaches for some tumors, chordomas, craniopharyngiomas, basilar invagination for sure, and slowly replacing them for certain skull-based meningiomas. Also, another tumor called esthesioneuroblastoma, juvenile nasal angiofibroma, other ones that we do, as well as cerebrospinal fluid leaks from encephaloceles. Transorbital approaches are just gaining favor. I think will be more widely used to reach the lateral cavernous sinus in Meckels cave. The future is unknown, scary like a dark tunnel. If we are brave and stick together, just like an endoscope, we can pass through the nose and pass through the tunnel and get a great view. And you can see this is sort of the advantage of the endoscope. You get to see a new, beautiful world of neurosurgical anatomy ahead of you in the future. So thank you very much.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.